Thank you very much. And I hope this is the only meeting we live virtually, and the next time to have the time to share some time together, because meetings is only not just scientific but also human meetings, and we need a really human contact. So my topic is pancreatic incidentaloma. I have no conflict of the interest disclosure regarding this presentation. So few words about the pancreatic incidentalomas. Except symptomatic pancreatic lesions, all other pancreatic lesions can appear as an incidental finding. Of course, malignancy is lower in a pancreatic incidentaloma than in symptomatic patients. However, malignancy histology is found up to 50% and the premalignant in up to 50%. In surgical service, so there is some surgical bias, selection bias, but this is an important message. Never underestimate pancreatic incidentaloma. And of course, a solid lesion of the pancreas must be considered a malignancy or potentially malignant until proven. We can have different features of pancreatic incidentaloma. We can have focal lesions, we can have a visceral alteration, and among focal lesions, we can have a pseudo lesions or hyperenhancing masses, pseudo solid lesions, hyperdense or hyperintense lesions, cystic lesions. Among the visceral alteration, we can have ectasia without stenosis or ectasia with stenosis. Among pseudo lesions, we can see sometimes we can easily observe, especially with the in-out of phase images, how the pancreas, the ventral zone of the pancreas in out of phase images, but also in with other secrets, we can see a difference of the signal intensity between the dorsal and the ventral zone. This signal is more easily evident in out of phase, and we see in out of phase there's a drop of signal intensity in dorsal dose, while the ventral pancreas maintains its normal signal intensity. So there's an embryologic differentiation between dorsal and ventral pancreas, and the embryologic differentiation is related to fatty infiltration. And according to histology, ventral pancreas are smaller, densely packed acini, and smaller exocrine cells with smaller nuclei, with scanty or absent interational fat. So this division, because we can have a fat infiltration which is different according to embryologic origin of the pancreas, and this is to keep in mind and not to make an incorrect diagnosis. In some patients, we can observe strange lesions in otherwise abnormal pancreas, like in this patient with a chronic calcifying pancreatitis, which has a solid, looks like hypervascular lesion in the head of the pancreas. So this is quite a typical zone. We could call also the groove area, paradoidal area, but it's not a paradoidal pancreatitis, of course, because this is almost a normal pancreas in otherwise affected pancreas. This situation can be related to abnormal embryologic differentiation of the pancreas. That means the dorsal pancreas in reality has two buds. Each one is independent for the drainage, and only the largest bud fuses with the ventral pancreas when it rotates. That means that this pancreas can have a different natural history from this pancreas, which maintains a different outflow of the pancreatic juice. So what looks abnormal in reality is just a normal enhancing pancreas in an otherwise hypovascular pancreas affected by chronic pancreatitis. And this is the so-called pancreas division inversion. When we see pancreatic masses which are high or hyperenhancing, we always must be keep attention, because like in this patient, at US was the patient has no significant clinical findings, but he performed a checkup at the US was enlargement of the head of the pancreas, which is also enhancing to the rest of the pancreas. The difference is that while the rest of the pancreas has a normal volulature, the head of the pancreas has a loss of volulature. This was a pancreatic carcinoma, still not leading to clinical symptoms. Remember that one of the signs of pancreatic cancer without any direct signs is a mass effect with a lost volulature. So keep in mind that this can be an atypical appearance of a pancreatic carcinoma. Of course, when we see a mass with the stenosis of the visceral duct, dilatation upstream, which is hypovascular or hypodense after contrast media, there is no way this is a typical pancreatic carcinoma. It was in the body tail of pancreas, that means very small. So for this reason, this patient has no symptoms and only a focal mass was discovered at US for checkup. In some situations, we can have a hyperenhancing lesion. And of course, when we discuss about hyperenhancing lesions, we think about pancreatic endocrine neoplasms, which are not really frequent, but day by day more frequently discovered, especially with lesions which are not syndromic. So in 80%, they are related to patients with MEN1, usually 50 to 60 body tail. Most tumors are functional and they secrete multiple hormones, but they can be syndromic. That means the secretion of hormones gives a clinical symptom, or not syndromic. That means which is not significant, they are not functional. They secrete hormones, but they do not give clinical symptoms. And we are observing in the last years an increased discovery of non-syndromic pancreatic and endocrine tumors. Many of these tumors are nowadays incidental. Either with CT or MRI, the lesion appears hypervascular. In my experience, these small lesions sometimes are much better seen with CT than with pancreas, because sometimes the pancreas with MRI, is a highly hyperintense of the also normal pancreas. So sometimes it can be difficult to differentiate with small lesions, much better visible with CT. But remember, sometimes, especially in the body tail of the pancreas, we can have problems with diagnosis. At US, a small hypoechoic lesion was seen at the tail of the pancreas. At CT, this lesion was hypervascular. At MRI, the lesion was again hypervascular. So the signs are similar to pancreatic and endocrine tumor. The lesion is a restricted diffusion, of course, and they see ADC map, the signal of the lesion is very similar to the spleen. And that time we also had still had iron oxide, small iron oxide particles. That means the contrast media, which was focused on Kupffer cells. And you can see here before and after STIO, this lesion becomes massively hypointense amplitude related to the uptake of this contrast media also by this lesion. So this was an interpancreatic accessory spleen. This lesion can simulate a pancreatic neuroendocrine tumor. It is important to make a differential diagnosis and remember always SNET can be seen with the Ductal PET CT. On the contrary, this was a SNET and well visible at Ductal, but not visible with the lamellar red cell damage, which is an imaging technique we can use to observe, to make a diagnosis for interactive spleen. Other techniques are fine needle aspiration with endoscopic ultrasound. But nowadays, also with the MRI, we can try to differentiate And in many papers, in reality, the ADC map of PNET has a higher signaling, higher values than intrapancreatic accessory spleen. So when the lesion has a very low ADC map, think about an intrapancreatic accessory spleen. Sometimes we can see what I call the pseudo-solid lesions or hyper lesions, hyperdense, hyperintense. What do you think about the pseudo-solid lesions? This patient has a hypertrophic lesion in the head of the pancreas, which was hypervascular CT. So the suspicion was to be an pancreatic neuroendocrine tumor. However, at MRI, we see the lesion can be quite bright on T2, no restriction diffusion. And so in reality, this was a very small serous cystadenoma with a honeycomb pattern, which means that the cysts are so small, so packed, that the stroma surrounding the cyst can be very well vascularized, thus with the imaging techniques such as ultrasound or CT, not very sensitive to liquid, they can simulate a small lesion, solid lesion, and hypervascular lesion. But with MRI, we can easily make a correct diagnosis of this lesion. And these are the other lesions, the hyper lesions. Sometimes these lesions are quite typically seen in the tail of the pancreas. They appear hyper intense on T1, either T1 normal, T1 fast cut, not enhancing with restricted diffusion, and they are typically hypo-intense tissue. This is a very typical imaging feature of a specific lesion. Whenever you see, you can then recognize them all the others. So this also CT appear hyperdense and non-unenhanced CT and does not enhance after contrast media. This is another typical features, and all these features lead to the diagnosis of a lymphoepithelial cyst. Why this lesion, which is a cystic, has this atypical behavior? Because this lesion is rich of keratinized material, and which is considered to be the cause for increased density on CT, high signal on T1, low signal on T2, with a water restriction due to the presence of a viscous fluid containing keratinized material. The sum of these features are very typical for lymphoepithelial cysts. You cannot miss the correct diagnosis. Then we can see cystic lesions together or not with the fascia of the viscera, that without stenosis. And whenever we see cystic lesion, the first question we have to solve is, are these lesions communicating or not with the main pancreatic duct? Because according to this communication, we can make a radiological classification. Non-communicating lesion can be mucinous cystic neoplasm, serous cystic neoplasm, pseudopapillary neoplasm, or other rare lesions. On the contrary, typical communicating cysts with the main pancreatic duct are IPMNM. Non-communication lesions most frequently in females, and we know there is an age range because serous cystic adenoma are more easily occur in women more than 60, pseudopapillary women in young women, and mucinous cystic adenoma in middle-aged women. So we can call them the tumor of the daughter, the tumor of the mother, and the tumor of the grandmother. The age is an important sign, information in order to try to better classify this lesion. For example, this is a young female with an incidental lesion at ultrasound, and we can see here this lesion with a small hyperenhancing lesions. This was a pseudopapillary tumor. This tumor can easily undergo even small to cystic and hemorrhage degeneration. And in this case, there was always still a small part enhancing, and the rest was just changing hemorrhagic change. But the most important question is to make a correct diagnosis between mucinous and the serous cystic neoplasm, because mucinous neoplasma are malignant or pre-malignant conditions, and thus they must be resected whenever possible. On the contrary, serous cystic neoplasms are benign lesions, and they can be leave and just follow up in order to see if they grow up too much. And the most important features to make a correct diagnosis is that lesions in males in the head of the pancreas are very unlikely to be using cystic neoplasm. A multicystic pattern is more frequently in serous cystic neoplasm, and oligocystic or macrocystic pattern is more frequently in mucinous cystic neoplasm. Mucinous cystic neoplasm occur almost exclusively in the body tail, whereas the serous cystic neoplasm have no site predilection. From a morphological point of view, the serous cystic adenoma, especially oligocystic adenoma, has a multicystic or lobulated contour with or without septation, whereas mucinous cystic adenoma has a smooth contour with or without septation. So remember, lobulated contour, think about serous adenoma. Smooth contour, think about mucinous cystic adenoma. And these are some graphs. Lobulated contour, multicystic, unicystic. These are typical for serous cystic adenoma. Smooth contour with or without septa. These are more typical for mucinous cystic neoplasm. So middle-aged woman, smooth contour with a high signal intensity content. This is typical for mucinous cystic tumor. More advanced the age, microcystic pattern with the scar, very typical for a serous cystic tumor. When the lesion is a quite young woman, but the lesion is growing, and there is a septa inside, smooth contour. This was resected, and this was a mucinous cystic tumor. Older woman, growing simple cyst, no septa inside. This was a serous cystic tumor. And once again, remember that the so-called honeycomb pattern, the cysts are so small, the stroma is so well vascularized that at CT they can appear as a hypervascular lesion, but in reality, this was once again a serous cystic adenoma. Sometimes we can observe some atypical patterns that is quite difficult to characterize this lesion in the male, in the tail of the pancreas. No septa, no restricted diffusion, no abnormal signal intensity, and this the contrast media, we don't see any significant enhancement. But in reality, if we perform a subtraction images, we see this small hyper-enhancing thick wall of the cyst. So, and these lesions turn out to be a cystic pancreatic neuroendocrine tumor. Remember that the pancreatic neuroendocrine tumor can undergo also to cystic degeneration, and typically they have a non-communicating cystic lesion surrounded by a ring of well-vascularized tissue that enhances the active space. Sometimes it's difficult to characterize the lesion, and even if small, we cannot underestimate this lesion. So we have to follow up this lesion. After 25 months of follow-up, there was a mass obstructing the lesion duct. So this was the first signs of a pancreatic adenocarcinoma. Remember that in a small lesion, about 20% they are represented by a typical hyperplasia or carcinoma in situ, and they can be observed by the small cyst, otherwise not very well characterizable. For this reason, the European evidence guidelines suggest that patients with undefined cyst should undergo lifelong follow-up unless the patient is unwilling and fit to undergo pancreatic surgery. And when the lesions are communicating, we discussed about the TMNS. We know it can be main duct, mixed branch duct, types, and these are very well known lesions to be followed up according to the size. So branch ducts are less aggressive than main ducts, like in this case. When we see a diffuse dilatation of some duct, we have to make a correct differential not with the chronic pancreatitis and duct dilation with pictures, the presence of stones, and side branchiectasia with non-cystic appearance are most difficult for a chronic pancreatitis. These lesions should be followed up. There is no still controversial the period of follow-up. However, all the guidelines agree that this lesion must be followed up because also the risk of degeneration increases with age. So this lesion must be followed up until patient is fit for surgery. Finally, the ectasia of the visceral duct with stenosis. Remember, whenever you see a stenosis with the ectasia, these are signs of a small pancreatic adenocarcinoma not clearly visible. So, and also when you see a follow-up in patients with a chronic pancreatitis, and you see a stenosis not seen before, which does not reverse after secretin, this is the signs of a pancreatic carcinoma in patients with chronic pancreatitis. Remember that secretin can be very useful to make the correct diagnosis. So, in conclusion, pancreatic incidentaloma can represent both a benign or as well as premalignant malignant condition. Never underestimate a pancreatic incidentaloma. Never underestimate the visceral stenosis ectasia. A solid high hypervascular pancreatic incidentaloma is a ductal adenocarcinoma less proven. A solid hypervascular is a net and less proven. Cystic lesion less than 50 meters without further features is likely to be still benign. Sometimes it can be difficult to make a correct diagnosis. However, clinical data are also important to make a correct diagnosis. And I thank you very much.